Good morning, everyone. This is Margie Giuliano, and I'm the Med Safety and ADE Regional Lead for the New England QIN-QIO, and thank you for joining us for today's webinar entitled Enhancing Transitions Through Technology, Connecting Individuals with Mental Health and/or Behavioral Health Needs with Appropriate Care. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute during the presentation, but we will unmute the lines after the presentation for questions. I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we still would like you to actively participate during the session by using the chat function. My colleagues Stephanie and Nayara will be monitoring the chat window and responding to your comments in real time. So please don't be shy. We'd love to hear your thoughts about what our speaker is saying and how you're addressing medication safety in your own practice. It's important to note that today's speakers have no conflicts of interest to disclose. The idea of using telehealth to expand access to care first surfaced in the 1960s, so it's not new. As clinicians struggle with limited resources, technology can facilitate access and delivery of healthcare services by linking individuals to qualified practitioners located at different sites. Today we're going to hear from two Massachusetts hospitals that are incorporating telemedicine to address their needs. One is focused on delivering school-based behavioral health counseling, and the other providing care and resources for patients requiring substance use disorder treatment. Both programs are supported by funding from the Massachusetts Health Policy Commission's Healthcare Innovation Investment Program as Telemedicine Pilot initiatives. The Massachusetts Health Policy Commission's Healthcare Innovation Treatment Program, or HCII, is a unique opportunity for Massachusetts providers, health plans, and their partners to implement innovative models that deliver better health and better care at a lower cost. So they're truly aligning with the AAA. The first phase of the HCII program, which launched this past summer, 2017, includes over $11 million in investments to 20 competitively selected awardees across Massachusetts. Awards are divided among three pathways, one of which is Telemedicine Pilot. The goal of the Telemedicine Pilot is to increase access to behavioral health care through technology. Two of the Telemedicine Pilot awardees will be presenting. Our learning objectives for this program are to evaluate how incorporating technology can enhance access and delivery of mental health care, to identify the role telehealth can play in providing substance use disorder treatment, and to describe key elements to a successful telehealth implementation. As I shared during this call, we want you to use the chat feature so that we can hear from you. So please chat in with questions and comments on the presentation, your initiatives and experiences, as well as what you might need some assistance with. So let's start by seeing who's on the call. Please type in your name, your role, your organization, and what state you're working from. Opioid misuse or addiction to opioids has become a national epidemic. The Centers for Disease Control has reported that 91 Americans die every day from an opioid overdose. Nearly half of all opioid overdose deaths involve a prescription opioid. We know that municipalities are dedicating resources to supply naloxone to their emergency responders to help reverse overdoses, and we know also that hospital emergency departments are flooded with overdoses and behavioral health episodes. When we look at some of the statistics, according to Sancha's National Survey on Drug Use and Health, in 2014, 15.7 million adults reported having a major depressive episode in the past 12 months, and there were about one-third of those that did not seek professional help. The same report showed that 21.2 million Americans aged 12 and older needed treatment for an illegal drug or alcohol use problem in 2014. And again, only about 2.5 million people received the specialized treatment that they needed. Sancha also tells us that in 2016, approximately 11.8 million people aged 12 or older misused opioids in the past year, which represents 4.4% of this population. Close to 900,000 adolescents aged 12 to 17 misused opioids in the past year, again representing 3.6% of adolescents. 8.4 million adults aged 26 or older misused opioids in the past year, representing 4% of this age group, and in 2016, approximately 11.5 million people misused prescription pain relievers in the past year, making it the predominant means of opioid misuse. Our current systems are not positioned to meet today's challenges. Providing the necessary support services for both patients with mental health issues and those with substance use disorder is a costly undertaking with many challenges. Telehealth could help to build a behavioral health system that assists people with mental health and substance use disorder to find effective treatments and services in their communities in a cost-effective manner. So what do we mean when we refer to telehealth? There is no standardized definition for telehealth among state or federal agencies, but according to the National Telehealth Policy Resource Center, telehealth is a broad term used to describe a variety of methods to provide virtual health care to patients through the use of technology. As you can see on this slide, there are several different examples mentioned. There's live video, which is a real-time interaction between patients and providers, so something similar to Skype, but of course over a secure platform. Store and forward refers to the transfer of recorded health history between practitioners. We more frequently see the use of remote patient monitoring, so systems that are used to monitor patients at home for either blood pressure or heart monitoring, etc. And mobile health, referring to practices that use mobile communications to discuss health care. Also, we know there's secure email that is being used as many practices move towards doing e-consults. The literature also shows us the value of how using telehealth can assist us. The Department of Veterans Affairs has been utilizing telehealth for more than 20 years, especially to serve their patients in rural populations with PTSD and other behavioral health issues. Referred to broadly, these services are provided either via telephone, email, or video conferencing. With provider shortages prevalent in both urban and rural areas, telehealth poses a possible solution to improve access to care regardless of location. And it also helps to address the issues of stigma and patient embarrassment. To practice via telehealth, it does require some training. Clinicians need to be trained on how to interact with patients, even with live video. It's really not exactly the same as being in the same room as the patient. There's also potential licensing and privacy issues that need to be addressed with telehealth, but with this becoming more popular, many of these barriers are being resolved. I think reimbursement is also a key issue. Medicaid and Medicare are starting to reimburse for these services as long as they meet specific guidelines. As more payers provide reimbursement, there will be a greater uptake in using telehealth. It's a great way to support patients between visits and answer their questions efficiently. Telehealth has the potential to lower health care costs and increase efficiency through better management of chronic disease and reduced length or frequency of hospital stays. And in some cases, particularly in mental health and ICU crisis, more timely access to specialists through telehealth services can be crucial to positive health outcomes. So again, we'd like to hear from you. During the presentation, if you are incorporating technology to improve access to care in your practice setting, please share with us via chat. How are you connecting with patients or other healthcare team members to improve care and communication? So it gives me great pleasure to introduce our first team of speakers today from UMass Memorial Medical Center. Starting this off is Dr. Alan Brown. Dr. Brown is a clinical professor of psychiatry with a joint appointment in family and community medicine at the UMass Medical School. He's led and developed hospital-based psychiatric services and programs for many years and currently serves as the Vice Chairman for Behavioral Health Integration and Population Health for the UMass Memorial Healthcare Department of Psychiatry and as the Associate Medical Director for Behavioral Health at the UMass Memorial Healthcare Office of Clinical Integration. His clinical interests focus on improving care for patients who find themselves poorly engaged with the healthcare system. More recently, he's focused on integrating behavioral health care in primary care settings and in medical surgical hospital units. This later work has included innovative program development for persons suffering from comorbid substance use disorders, hospitalized for either the direct sequelae of their substance use or for significant comorbid medical conditions. Joining Dr. Brown is Hussam Zefi-Bahloul, an assistant professor in the Department of Psychiatry at the University of Massachusetts Medical School. He's the medical director of the Addiction Consultation Services at UMass Memorial Healthcare Hospital, including being part of the Telemedicine Consultative Service. Dr. Zefi-Bahloul is the author of multiple publications in the field of refugee mental health, telemental health, and global mental health. We also have joining us Peter Zarotniak, a licensed social worker and addictions counselor, who serves as the program manager for the HPC grant and the hospital-based addiction consultation service. He originally trained in Poland as a psychologist and has extensive experience in providing substance use and behavioral health treatment in general hospital settings. I will now turn this over to Dr. Brown.
Good morning, everybody. A pleasure to be here. I'll try to keep the presentation shorter than the introduction. So I'm very happy to report out on a program that we have initiated with support from the Health Policy Commission to bring a telehealth platform to provide addiction consultation services in a general hospital setting. I'll provide a little bit of background and then just go over the intervention and hopefully talk more in the Q&A if you have questions or details you're interested in. So a little bit of the background. We are a two-campus hospital in Worcester, an urban setting. We have 654 beds, very busy emergency department, 38,000 admissions a year. And like many of you, Worcester is a hotspot for opioid overdoses and hospital visits related to opioid use. The addiction consultation service that we have had prior to the more recent Tele grant was started with a series of infrastructure grants from the state, and we have been able to get the hospital to sustain those projects, which is always a challenge. The team on the university campus has had a third of a psychiatrist, one social worker, and 2 recovery coaches, and we've been able to double that thanks to the recent grant, and I'll go over the details there. And this has allowed us to bring a tele-component to our second campus, which is called the Memorial Campus, and I think we'll provide a model for cost-effective expansion of services in this area. So the problem. As you all know, substance use disorders are frequent comorbidity in hospitalized patients. It's associated with very poor clinical outcomes. Patients are at a high risk for and high ED use. And our own claims data indicated just with using discharge diagnosis criteria that 16% of our patients had a significant comorbid substance use disorder. And as we know from other studies, the actual incidence is several-fold higher. And primarily alcohol as compared to opioid in a 3-to-1 ratio. Before we started our initial consultation service, the treatment as usual was really not effective in the med-surg setting. The standard of care usually was medical teams doing the best they could, a lot of variation in practice. The social workers would try to help patients, primarily have a list of resources they could access post-discharge. There was no proactive identification of patients, no initiation of MAT, no capacity for referral to residential treatment, very limited Narcan kit education distribution, no post-discharge follow-up. We had real problems at our hospital with 30-day readmission rates. And we actually did a local study where we looked at decedents from death records in our area, tracked their use at our hospital in the prior year, and found that about 70% of patients that had died of an opioid use accidentally had been seen, and of those patients, half we had identified as problem users, but a full half that had not even identified as having problematic opioid use. So the challenge was, could we take what we had done on one campus and put it on another using limited resources, and we felt that Tele would be a great opportunity to try to extend ourselves. So here's what we set up, and I'll go over this a little bit, and we can talk more about details. So in terms of patients entering, our traditional referral pattern had been hospitalists and hospital social workers calling our consultation service and asking for a consultation. We would do some education about who we were looking for, and we continue to do that. As part of the grant, we were trying to add a proactive identification program. Some of this we've started where ED screeners will let us know at admission a patient might be suitable for our service, and we've been working with our IS department to develop algorithms to help us narrow down of the 100 patients who come in each day to the hospital, are there 15 or so that we could screen using the electronic record to see if they'd be suitable for our service. And finally, looking for our partners in the community to be able to tag and flag patients for us that they would like us to see when they come in the hospital. Our recovery coach does the initial engagement. We'll meet with the patient, screen them, provide some preliminary data and assessment for the rest of our team, really try to engage the patients. These are all folks with lived experience and have really been a tremendous addition to our facility in many, many ways. And they'll follow the patient throughout the stay, and we'll provide post-discharge follow-up as well. Most of the patients are then seen by the social worker, who has a range of clinical skills, and Peter's on the call. The social worker is specialized in addictions, knows our community resources, and provides a more robust clinical intervention when these patients are here, and comes up with a plan and tries to execute it. And then about 30 to 40% of the patients will see our psychiatrist on one campus that's live, and on the other campus that's been through teleconsultation, and he will assess the patient and help the team initiate MAT as appropriate. And then there's some discharge follow-up where we're continuing the MAT and trying to connect patients to these other resources and services, including residential treatment, community treatment, follow-up with the PCP. And as I said, the coach is available for follow-up post-discharge. In terms of the telehealth applications themselves, we've started going live with the grant in June. The psychiatric consultation portion is up and going. I think the headlines are that this has been feasible. The technology has been very easy once the bugs were worked out. There are differences about doing the consultation via tele versus live, and we do feel that the use of the coach plus the laptop provides a very cost-effective way of helping the patient adapt to this novel approach. We are planning to put other services on the platform. This includes piloting social work consultation. We have pilots set up with one of our community providers to do intakes at the bedside of the hospitalized patients so they can follow up at that clinic with outpatient services upon discharge, providing a warmer handoff and hopefully better continuity of treatment. We have an ED intervention we'll be piloting where when our patients present to get an ED, we do have a screening program there, and they will be connected via laptop or iPad to our team. And as I said before, we are working on the patient identification. The results to date have been basically very good. We have been able to rapidly staff up for our second campus, and we had a go live date in June. The Telehealth consults are up and going. Our run rate of patients, we are able to screen a lot of patients this way and make a lot of contacts. Our target rate is 80 patients per month. We're already almost there, and we think we'll be exceeding that over the course of the year at about 90 to 100 patients a month. Again, 2-to-1 ratio with alcohol to opioid. We are establishing the coaching contacts. We hope to improve that number. And again, you can see that a little over half of patients have been seen by the social worker. About 36% are receiving a visit by the psychiatrist via tele, and our overall MAT initiation rate on both campuses is about 35-40% of those patients. So we think we're off to a really excellent start. The initial feedback from staff has been just robustly positive. It's really been a pleasure to come together and collaborate on how to help very challenging patients. And as you can see, we will be following up. We have a number of indicators we'll be following to really try to see if we can demonstrate better engagement post-discharge, as well as reduction in all the typical hospital utilization numbers, including 30-day readmissions, ED visits, and AMA. So to summarize the lessons learned, we think this model does provide, at least our initial findings, a very feasible and engaging approach to help patients, to lend expertise that isn't always readily available at many hospitals in a way that's efficient and cost-effective. We are really looking forward to piloting during the course of the year. It's really been fun to connect with partners and see if we can come up with some novel approaches, and we'll be exploiting that over the course of the year with the iPad technology. The technology really is the easy part. Getting the community aligned with what we're doing, as most of you probably know, is the real challenging to create meaningful dispositions for patients while they're in our hospital. There's been a lot of intangible and really nice things we think we're seeing. We will hope to measure some of that and really broader acceptance of addiction as a disease in our hospital and really helping the hospital overall feel that they're being effective in helping these patients, and it's part of the treatment that we provide in the general hospital setting when that's such a driver of the patient's clinical conditions and other problems. And we will see whether the hospital itself does provide a unique opportunity to engage very hard to find and connect with patients. So I'll let you know at the end of the year. So let me hand that over, I guess, to Rebecca, and I think we'll come back to the Q&A later.
Thank you, Dr. Brown. That was a great presentation, and I'll now introduce the members of our next team at Haywood Hospital. Rebecca Bialecki is the Vice President of Community Health and Chief Agent of Change at Haywood Healthcare, well known in the region as a visionary and voice for the underserved and at-risk populations. She leads strategic projects focused on improving the overall health of the region's residents, including development and implementation of a unified telemedicine platform to improve access to specialty care. Presenting with her is Maureen Donovan, the Program Manager of the Telepsych Grant. Maureen's a graduate of the University of Massachusetts Amherst. She began her career in the field of health education. She developed and implemented district-wide school health programs, and after much success in public health, she moved on to creating middle school alternative programs for at-risk youth. Ms. Donovan has a particular interest in implementing telehealth services to varied populations. Her awareness is fostered by her recent role as a drug-free Community Grant Coordinator for a local school district. Starting off the discussion is Dr. Milwaukee. Rebecca?
Good morning, and thank you, everyone, for giving us this opportunity to speak to you all about our project. We are with Haywood Healthcare, which is a 3-campus small community health system in north central Massachusetts. We serve 15 towns that are split between Worcester County and Franklin County. We are a federally designated medically underserved population area. Geography contributes to social isolation and impacts access to care. We are very sparsely populated. We have 4 different regional school districts across our region, and so it's been difficult to get people to care with very limited public transportation and other geographical challenges. So our problem was really centered around access to behavioral health services. It's very difficult to recruit good quality clinical staff to our region because we are a little bit isolated. We certainly have access issues on the patient side because of lack of transportation services, all the stigma, the difficulty of having to travel a good distance to get the kind of psychiatric and psychological help that folks really need, especially in our adolescent population. We have socioeconomic factors such as multi-generational poverty in the region and very difficult access to higher education and other issues that come into play as far as some of the socioeconomic factors that contribute to behavioral health, depression, anxiety, and substance use disorder in our region. The increased need for behavioral health in our adolescent population has been very apparent, and we had the opportunity to work through a chart grant from the Health Policy Commission up to this point that really sort of solidified the data to show us some of the real issues and challenges we were dealing with within 2 of our school districts, and this innovation grant allowed us to expand that similar kind of service and access to behavioral health supports into 2 additional regional districts. We have a very high suicide mortality rate. We have a particular problem with students reporting anxiety, ADHD, sensory processing, depression. 30%, close to 30% report feeling hopeless. In 2015, our community health assessment indicated that adults and youth expressed concern about the health of children and adolescents in the region due to lack of physical and mental health resources. So at this point, I'm going to have Maureen pick it up and talk about our partners and our project specifically. So Maureen, go ahead.
Thank you so much for allowing me to be here today. This is really fabulous. I am the program manager of this wonderful grant opportunity, and I created the next couple of slides just to talk to you a little bit about what the process looks like. We need to be partners in this, and that's how we have rolled this grant out. We have 6 partners. Haywood is assumed, but we also have McLean Hospital, the Northeast Telehealth Resource Center, our 2 high schools, Mary Anton High School and Mahar High School, and clinical support options, which provide our clinicians. And the lesson learned here in terms of partnerships is the fact that it has to be a team approach. We need to get out of our silos and work together cooperatively and collaboratively. When you bring in a hospital, you know it's all about HIPAA. When you bring in a school, it's all about FERPA, the Family Educational Rights and Privacy Act. And when you work with clinicians, it's about the intake process. So what we had to do to bring telehealth, telebehavioral counseling to our schools is to create a seamless approach to this and a process, and a workable process. And that took a lot in the preparation period of this grant. And doing that had us ready to start when the school year began this year to roll this right out. And as Dr. Brown would say, go live with it. So in the next slide, okay, Rebecca's got my phone here. There we go. I want to talk a little bit about the process. And I want to back up for 1 second. I didn't say one thing, that our evaluator is also the Northeast Telehealth Resource Center, and that's really, really important for anyone out there who really wants a good resource. They're fabulous, and they really know what they're up to in terms of evaluation and developing the data around your outcomes here. And McLean Hospital also does a lot of training and professional development for our teaching staff in our schools, as well as our school-based care coordinators. And I wanted just to give a shout-out to them, too. When we're looking at our aims here, and that's very obvious, I don't need to read them to you, we need to do a 10% increase of access for behavioral health and a 10% decrease to crisis intervention in the schools. The key piece on the slide I want you to focus on is our primary drivers. This was really the process about how do we do this? How do we bring clinical services to a school? Our young people don't leave school. Our school-based care coordinators set up this process for them, and they can do everything on campus, which is absolutely fabulous because a lot of times out here, as Rebecca mentioned, transportation is very, very difficult. And a young person that goes out for counseling during the day never returns to school. And then that creates all the stress and anxiety of absenteeism and all of that. So this is really working out very well. I want to backtrack a little bit to our school-based care coordinators. In our primary driver, it says develop a process to early identification and referral for behavioral services. This is the key piece. Our school-based care coordinators, I can't say enough about them, are responsible completely and totally for this driver. The process looks like this. I'm a student. I have anxiety. I go to my guidance counselor. I'm very, very upset. I don't know what to do. The guidance counselor considers the telebehavioral program for the student and calls the parents. The parents, they explain it to the parents about the program, and then they do a soft handoff to our school-based care coordinators. Our school-based care coordinators work seamlessly. They call the parents. They tell them about the program. The parents sign on. The parents come to the school where all the telemedicine equipment is ready to go. The platform's ready to go. They come on into the room. The clinician is in Pittsfield, Massachusetts, which is about 100 miles from here. She comes in via tele and the parents and the students sit with the school-based care coordinator for the intake process. And once that's done, all the school-based care coordinator works with all the paperwork and gets all that set. And then we have the counseling session start. Another shout-out to the school-based care coordinators is that they also work in community and family resources with families, creating a safety net for them if they are in need of any type of other services, and it's not specific to counseling. It's whatever community resources they need, they can reach out and help them with that. We harnessed our technology, and we created increased access. We've worked with the IT people in the schools. They are critical, and they helped us get our platform up. And at this point, we're developing a financial sustainability model for the future, and I'd love to share what that is with you, but it's still in development, so I can't necessarily let you know about that right now. But if you want to reach out to me in about 3 or 4 months, I can share what the plan is. And I want to talk about success. I did this slide a couple weeks ago, and all the numbers have changed, so I want to just review with you. Since the rollout of the program, the new school year, so we started August 31st in the new school year, we have 19 clinical intake scheduled, and our clinician only has 25 slots, so we're almost at 75% capacity, and we have 315 documented contacts with students and families. So this is an amazing program, working really hard. I'm really, really excited to see what the data shows as we move forward, and anytime you need to reach out to me or want any more information about this, please do. I'm here for you. Okay, Rebecca, back to you.
Thank you. So the keys to success, number 1 is patience. There are going to be bugs along the way. Really important to remember that. Just take one small piece at a time. Don't try to just come up with everything at once. It's really a team approach. We are bringing together 3 different institutions that all have very different cultures, very different expectations, different ways of measuring things, with school, community-based organizations, and a hospital system all coming together to build this model. You have to work through some of those cultural issues as you go. Really having every member of the team be valued, really having every member of the team feel like their part is just as important as the others is a really critical way to take an approach to this model. You have to understand the environment. We are in a very rural area, so broadband is sometimes not always accessible. So we had to figure out within these two school districts what was the platform that was truly going to work best for this system to work, and we've done that through some trial and error. We have to have clearly defined roles. We have to have a very clear understanding from the outset of what the clinician's role is. This is a little different model than typical ongoing outpatient therapy because that's not appropriate for an in-school setting. This is more of a triage model where they are there for support. It is intended to sort of be preventive instead of having to have students go into full-blown crisis and perhaps require hospitalization. We are able to step in with a clinical master's level clinician to address and provide some supports and some short-term interventions around that child's behavior and some of what their needs are. The school-based care coordinators have to have a very clear role as well. One thing that we had dealt with in the past was that guidance counselors sometimes feel a little bit threatened, like their job is somehow going to be at risk because we are bringing in these other folks to help support children and families. In fact, it's intended to supplement the guidance counselor role or school adjustment counselors in order to make their job easier and more doable in a climate of decreasing resources for schools and budget cuts all around. The other piece is to, right from day one, start thinking about how are you going to sustain this. Is this a way that we can continue to maintain good access for our patient population and still be able to find ways to pay for this? And in Massachusetts, that's a particular struggle until we get a telehealth parity law passed. There are some insurers that still are not equally paying for a telemedicine visit.
I'm going to hop in.
So I'm going to turn it back.
I just want to say, I think there's somebody that's unmuted, so if everybody could just check their phones and make sure that they're muted, or you can press *6 to mute your line. Sorry, go ahead.
That's okay. I can hear that little voice in the background, too. I thought that was my time cue. So the next slide, the final slide here, is really our contact information. Maureen has done a wonderful job of really building this program. I think another clear key to success is Maureen's background has been in the education world. She understands systems and culture of schools. That's been an important partnership to have her be part of this model to design it, because if it's going to run in a school-based setting, you have to have someone who understands the lay of the land within that culture. It would be much more difficult if we were trying to insert a clinical or a healthcare provider, administrator into that role. So I really want to thank her. So feel free to get in touch. And I'm going to turn it on back to our host.
Thanks, Rebecca. So let's open it up for discussion and questions. Morgan, can you remind people on how to unmute their lines? And while we're waiting, we'll look to see if there are any questions in chat. So Morgan, go ahead.
So if you'd like to ask a question over the phone, just press #6 to unmute your line, and you can ask your question. Or as Margie mentioned, you can always enter your question in chat, and we will make sure to read it to our presenters.
Great. Thanks, Morgan. So, Nayara or Stephanie, are there any questions in chat?
There is, Margie. So from Ruba, she was wondering if, I believe this is for Dr. Brown, are you randomly assigning care? You mentioned 15 patients, so is this a randomized treatment?
No, so it's very much not one. So really one of our goals is to be able to identify patients where we really think we can make a difference and to be able to stratify the need and the risk. You know, one of the challenges in a hospital is most consultation relies on reaction to a referral, and that can lead to huge variability, particularly in a teaching hospital where there's just a constant churn of our staff. So trying to get some consistency, making sure we're getting a good snapshot of everybody that's in the house, and then can we figure out who really needs help with their substance use disorders is the goal. And we're really trying to improve our ability to find those patients. Some of that is staff education, but some of it's also trying to use new IT tools to be able to identify patients in the ED. We talked to IS about using word searches in the EMR, et cetera, so that we can really hone it down to a smaller number of patients where we have a chance to sort them out through a quickie chart review in the morning using the electronic record. So those are the folks we're hoping to gather. And fortunately, it's not a randomized study. It's really a pilot effort to just see what we can do to optimize the care.
Great, thank you. Any other questions in chat, Stephanie or Nayara?
No, not at this time.
Okay, any questions from participants on the phone? Remember to hit pound 6 if you have a question to unmute your line. So while we're waiting, I'd love to ask the big question about sustainability. I know that Haywood made a little reference to it, but I was wondering if, starting with either one of you, what you're doing to look towards sustainability with this work going forward. Any suggestions, recommendations?
We'll be right back with you.
Somebody's doing on hold.
So this is Rebecca. I will try to respond to that. So we know that the care coordination piece, which is the staffing that is in the schools that is coordinating these televisits and also providing family support and connections back to the other agencies and the organizations involved, is a really critical piece. And probably the most difficult piece to pay for. I do believe that in Massachusetts we will soon be able to bill for the telemedicine visit, just like you would for an office visit. But the care coordination is really an underpinning of the model being successful. So we are always trying to find ways to really advocate for those community health worker and care coordination physicians to become part of the norm. I know there's been some efforts around recovery coaching and being able to bill for those kind of positions. And this is another model that really is similar to that. You need to have folks who are more lay people level really be able to coordinate care in order to make it successful. So that's an ongoing struggle, but I think one of the keys to sustainability is making sure that you have some funding to be able to pay for those positions as well.
Yeah, I could just add a few things to that. Of course, trying to advocate for reimbursement structures in any kind of psychiatric or behavioral health or substance use consultation in a hospital would be a great result. We're also trying to understand, management leadership's concerns in the hospital and make the business case that these kinds of interventions can bring direct and immediate improvement to their performance. So that is something that we have a lot of interest in, and actually has succeeded at moving from grant to sustainability without getting a reimbursement as well. Some of that's been able to show reductions in your length of stay, which yields immediate returns to the hospital. Some of it has been reducing other costs by having challenging patients well managed in the hospital. Some of it has been understanding some of the hospital priorities around public broadcasting of their quality indicators like readmission. So there are these leverage points where these are very inexpensive interventions as things go in a hospital setting, where we have been able to successfully advocate past the grant period. And so, I didn't go over my email there, but I'm actually quite happy to talk to anybody that's trying to get these things bootstrapped in their organizations about some of the arguments we've been able to make, and to be able to disseminate a little bit about the business model arguments that can be made.
Well, certainly, I would assume with all of the data collecting that you're doing regarding both of these projects, hopefully that will encourage other payers to jump in. I was wondering if anybody on the phone might want to add to some of that discussion. Anybody providing telehealth services that is billing and successfully being paid for those services? Hearing none. Hearing none. What else? Do we have any other questions in chat?
We do. We have a question from Luis. For both models, how have you determined who is involved during the telehealth consult supporting the patient?
So this is Rebecca, and thank you for that question. I think this is an important piece to know. We actually have the care coordinator who is based at the school and knows the student, knows the family, be the person who's able to be present for the consult. Although it really is the student and family's choice as far as who is present. So there are times when the parents do come in, especially at the point of intake, but the parents are not typically there. It's typically the care coordinator, and we sort of leave it up to the adolescent to choose whether they want to have that care coordinator sit with them while they do their appointment with the clinician or not. So they really are in charge of that.
Let me hand this one off to my colleague, Peter Zlotniak, who's on the phone. And maybe, Peter, you can talk a little bit, if you're hearing this, on some of the issues around patient acceptance and the coach's role in helping them out with that. I probably will have to imitate Peter's voice and offer the answer to that one. So in our model, the recovery coach has been critical around patient acceptance of the technology. So they prep the patient and they explain what we're doing. Initially, we didn't have this down too well, and I don't think any of the iPads were thrown, but there was a little hesitancy there. So the coach really has done a great job. Most of the patient acceptance is extremely high, and a great deal of comfort with using this. It is understood that, this is an opportunity to have access to a psychiatrist, which has been hard for many of them to get, and there's been ready acceptance. The coach does sit there through the interaction. Often they'll stand a bit aside to allow some privacy. Consultation in any regard in the general hospital setting has real privacy problems to it. There's a lot of people coming in and out. There's a patient in the next bed. So even without the tele, these are problems for us. And there are some differences for the psychiatrist in trying to create a certain connection over the phone. But those have not been deep barriers to the implementation, and the overall satisfaction has really been markedly high. There's a lack of control of the room, which is tough enough in a hospital. Dietary will walk in, a nurse will come in, and that is magnified when you're remote. So having the coach present, letting people know that there's an intervention going on, it's been helpful. So that's been our experience with those kinds of questions.
Yeah, this is Peter. Can everybody hear me, actually?
Yeah, good, Peter.
Yeah, so just to add to what Alan said, I have to say that the response from the patients was extremely positive. These are patients who were historically kind of lost in a sense, so the idea of those patients of being able to be actually introduced to medications, and we're talking about methadone, Suboxone, any kind of medications that will help them with the recovery is something that they truly do appreciate. Also, the feedback from the rest of the hospital has been extremely positive. Frequently, social workers, attendings, they usually did not know what to do with those patients. They had difficulties navigating the whole system of substance abuse treatment. So this is where we can be very helpful, not only to the patient, but also to the rest of the staff in the hospital, nurses, attendings. So I have to say that so far so good, and I'm hoping we'll continue extending this whole program.
Thank you, Peter. Do we have any other questions, Steph?
We do. We have a question from Luis in chat, and this would be for Maureen and Rebecca. What would you say is the patient-student experience of the telehealth model so far compared to in-person sessions?
So one of the earlier adopters of telemedicine as a whole are definitely this younger generation. So I think there's been a very easy acceptance. These adolescents in particular are very comfortable with a video-visual platform. They're used to Skype. They're used to social media. This is how they communicate typically, so it's not unusual for them. The parents might be a little bit more difficult to get comfortable with it. But there's also a certain, when it comes to telebehavioral health in particular, I think it puts a certain safer distance between the clinical person and the patient, so they don't feel as much burdened by, revealing very private personal issues and struggles to a stranger, because they're not in the same room, they're not in their space. So I think in some ways it promotes a little feeling of safety for the patients who we've dealt with so far.
And also, too, just to add, Rebecca, I think the students are way more accepting of this modality than maybe even a lot of the clinicians still. And I'd like to see some of the clinicians, get on board with and be more comfortable with telebehavioral, because it took us a bit of time to find a person that would really jump on board and love this. Because a lot of times clinicians are very, very comfortable doing the in the same room modality, and so now that we have this fabulous clinician who's jumped on and has learned to use the platform very creatively, it's going very, very well.
That's great. I think we have time for one more question. Are there any questions from the phone? Remember, if you'd like to ask a question, unmute your line. To unmute your line, press #6. Any other questions in chat, Stephanie?
Hi, Margie. There are currently no other questions, but I also wonder if Dr. Brown would like to speak to the patient experience of the telehealth model so far and how that's compared.
Thank you. Yes.
And Peter, please chime in on this. So again, it's been remarkably positive, and just as Rebecca Marine indicated, the older you are, the more the barrier, perhaps. The clinicians, more issues than the patient. So patient acceptance has been really quite good. And we're very fortunate. Our consulting psychiatrist did already have some experience in the tele realm. For him, there are differences probably more noticeable than for the patient. And being able to really keep a handle on the interview, often, we're engaging patients with all sorts of different states of pre-contemplation in their treatment. So it may not be the easiest group to engage. So some of the softer variables are the hardest, and we're blessed with a very good psychiatrist, a very good team of coaches and social workers, which have really made that engagement part easy. That's probably the biggest challenge. You don't really control the interview to the same extent in a tele format. Peter, did you have anything you wanted to add to that?
Yeah, I have to say that. Can everybody hear me actually?
Yeah.
All right. I have to say that the response so far has been extremely positive. You have to remember that for a lot of our patients, this is actually the first opportunity to actually see psychiatrists, be induced to medication. There is a lot to be said about actually prepping the patient for consultation via telemedicine. So before we do it, we explain the whole process. We explain what it's all about. We do not want the patient to be surprised or shocked by us bringing iPad to the room. So once the patient is prepped, usually everything goes very smoothly. And I cannot stress enough how important it is to keep in touch with the whole community, because all the patients that we do start on medications, it's very important for us to be able to refer those patients to outside providers who will continue medications. We do have a very good connection with some providers in Worcester. We did make a deal with some of them, so all the patients who are induced to medications in a hospital settings, whether it's Suboxone, methadone, Vivitrol, or any other form of MAT, they will get with those medications on the very next day after discharge by those providers. So that being said, the feedback from our patients has been extremely positive because, like I said, for a lot of them, that was pretty much the first chance to get some real treatment that they've been missing frequently for years. That's it, I guess.
Great. Thank you so much for your comments. I think this has been a great presentation, and we've all learned a lot of the value that telehealth can bring. Just in your final comments, it would be interesting in how we really do focus on some of those medication-assisted treatments and engaging other providers to follow up and monitor. As you can see, I've just flipped the slide to provide you with some contact information for the Medication Safety State Lead. So if anybody has any questions, please, you can reach out to any one of the people listed on that slide. For those pharmacists who are claiming continuing education credit, the ACPE code is Telehealth. You'll be able to enter that information when you complete the session evaluation. Others who complete the evaluation will receive a certificate of attendance. And I will now turn it back to Morgan for a wrap-up.
Awesome. Thank you, everyone, for a great discussion. Just a few announcements before we end today's call. As you can see from this slide, we're now on social media. So please connect with us on Facebook and or LinkedIn for the latest webinars, resources, and other offerings from the New England QIN-QIO. As you close out of today's webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation now, or you're sharing the computer with somebody, or you're running to another meeting, we will be sending an email tomorrow that will also contain a link to the evaluation. I know we mentioned at the beginning of the webinar that the PowerPoint slides were on the website. They were not at the beginning of the webinar, but they are now. So I know that link has been put in chat a few times. So make sure to go there and download the presentation from today. And within the next few business days, we'll also add the recording and a transcript of today's event. Thank you again for participating, and we hope you have a wonderful afternoon. Bye, everyone. Thank you.
Bye. Thank you.
Bye.
The leader has disconnected. The conference will be terminated in 5 minutes.